Hello everyone, this is the remaining topic of the myopathies, the part 2. The genetic counseling is in the sum of the most common myopathies such as the Duchenne muscle dystrophy DMD. The only interventions that can prevent disease. Give the genetic counseling early. Test early for carrier status where appropriate. Consider the perinatal diagnosis testing where the appropriate advances in molecular genetic may help the father. Now come the physical therapy. The physical therapy, as long as the patient can maintain the line, the gravity behind his hips in the front of the knees and within the base of the support, he can stand upright. Gait requires the body unbalancing through the coordinated activity of the tibialis anterior, the quadriceps, hip abductor and the personal muscle, peroneal muscle of porosis Duchenne dystrophy patients find the difficulty to perform. To execute the swing phase of the gait, the hip must extend and the extensor muscle upload. The muscles of contracture occur in the postural muscle spanning the joint. The muscular weakness, the tendon contracture, and the mechanical malposture contribute to ultimate deformity. An outline of the biomechanical sequences leading to the typical dystrophy posture is as follows. First, the hip extensor and the shoulder stabilizer weakness. Hip flexor contracture, thrusting the trunk forward, the compensatory lumbar lordosis. The forward shift of a center of a mass forcing the patient to the rise on toes. Thus, the shortening ankle to toes, the lever arm, and shifting center the gravity forward. Hip abduction to increase the equilibrium by the widening body of the base of support. Secondary TFL contracture. External tibial torsion, thus the ankle and knee axes are no longer in the sample plane ankle virus. Mild knee flexion to the lower center of the mass and the gain balance. Progressive quadriceps weakness the required to the lock knees for stability. With foot fixed in equinus and the knee flex, the gastrocnemius and the soleus can now act to extend knee. Through overwork, the exercise, the hypertrophy of the calf, generalized weakness make it the increasing difficulty to attain the alignment stability when the trunk is balanced over unstable the lower extremities. Proprioceptive abilities are also affected. A slight weight gain or a period for several days of a bed rest can decrease the strength enough to impair ambulation. In its later stage, the DMD is a brittle disease and transitions from the moderately to several impaired. Ambulation may be abrupt because of individual difference in weakness, contracture, weight, and the motivational is alone is a poor index disease the progression. The more disable of the patient The more determines the gait or the lost, the more energy is required for ambulation and the less efficient is the gait. Now comes the assessment. First, strength and the range of motion, shoulders, hips, knees, etc. Contracture, hip flexor, TFL and TA. What is TFL and TA? Transfer facilis and the tibialis anterior. Functioning, rising stairs, walking, etc. The patient ability to perform a number of standard tasks is assessed by measuring time required and the observing method employed to complete the task. Subtle the alternation is the method as well as the slight changes in the time needed for any given task. Objectively reflect changes in strength. The patient can be rated on a functional 10-point step scale. Stage 1. Walk and the climb stair without assistance, without any support. Stage 2. Walk and the climb stair easily with aids or a rail. Stage 3. Walks and the climb stairs slowly with aids of a rail. Walks but cannot climb stairs. Stage 5. Walks unassisted but cannot climb stair to get out of chair. Stage 6. Walks only with assistance or only with braces. Stage 7. In wheelchair, sits erect and can roll chair and perform bed and wheelchair activities of daily living. Stage 8. In wheelchair, sits erect but is unable to perform bed and chair activities without resistance. Stage 9. In wheelchair, sits erect only with supports and able to do only minimal activities of daily living. Stage 10. In bed, cannot perform activities of daily living without resistance. The kinetic sequence of the above scale provides the treatment for the physical therapy program. In stage 1 to 3, the patient is ambulating independent, passive stage early. Lower extremity contracture may be necessary by the stage 3. Functional activities of the daily living and the ambulation are sufficient activities exercise for stage 1 to 3. Between stage 5 to 6, lower extremity surgery is indicated because the contracture leads is the increased difficulty with anti-gravity activities where the contracture is minimal or absent. Orthotic modification or bracing alone may be sufficient to augment the weaken the knee extension and keep the patient ambulant. Ambulant the patient in stage 5 and 6 should not avoid activity and use wheelchair except when absolutely necessary and for only brief periods of time. Stage 7 should not be skipped as a patient is thus the consumed of to stage 10 immediately. When stage 7 is reached, routine conditioning exercises are the prescribed to retard discus trophy and maintain independence in wheelchair activities. Prophylactic treatment of scoliosis is also initiated at the time as well as the full program of respiratory therapy. Obesity is usually to perform after say stage 6. The closer a patient is to stage 10, the more assistive device he requires. Climb set stair. Independent, foot over foot, no assistance such as the pushing on knee using a rail. Independence, one step at a time. Hands on the knee, assistance from a railing of one hand, railing and a hand on a knee. Patient pulls on rails without on a hand, pushes on a knee with the other. Railing to hands, some patient may use to rails. Walk down at a stair. Independent, no assistance from a rail, may go foot over foot or one step at the time. Railing, one hand often used for safety but not for support. Railing, two hands or a rail and a therapist hand for safety. Rise from chair. Care must be taken to sit the patient in a chair which places his feet flat on the floor and his knees in 90-degree flexion. This is particularly important with the children. Higher chair would be given them mechanical advantages. Independent, rising without pushing on a chair or a knee, arm folded across a chest or extended. War sign includes the pressure on a knees or a pressure on a seat of a chair or a both. Assessment also includes range of motion, assessment in all position and transitions between the positions, MMT, the manual muscle testing, vital capacities analysis, the spirometry, pattern of breathing, gait assessment, assessment of ADL, and physical environment accessibility. The physiotherapy management, the goals of the physiotherapy management, short-term goals, the long-term goals, the first two contribute the short-term goals. To increase or maintain the range of motion of the joint, to increase or maintain the strength and endurance, the promotes protects the body alignment, the symmetry, to maintain ability, to provide an active respiratory program, to strengthen and maintain respiratory muscle endurance, to promote relaxation and the comfort. What is the long-term goals? To prevent deformity and contracture, to maximal and maintain muscle strength, to maximize and maintain respiratory status, to maintain the ambulance to long as possible, to maintain the highest possible as the functional independence, the usually adaptive equipments and the orthoses are needed. PT interventions, the physiotherapy interventions. Strengthening exercise, the muscular activity enhances the contractile protein synthesis. Functional exercise, the non-executing functional exercise may be helpful in maintaining strength. Patient with a DMD suffers of dyscalcitrophy when immobilized. Bed or a chair convenience should be on for no more than the day at the most. Alternative helps standing in cross the avoid heel cord contracture. Although weakening is asymmetric in many muscular dystrophy joint, the contracture are not so. The patient with a muscle disease should be kept the orthograde for the long as possible. Standing and walking are the best functional the physical therapy for acute closing this 2 or 3 hours a day such activity in course. Night sprints and sometimes also effective is preserving joint posture. Where low extremity night sprints are used, KAF4. Knee, ankle, the foot orthosis are advised as the ankle foot orthosis, the night splints may be initiate or increase the knee flexion contracture because of the tendency of the patient to flex their knee in order to relieve discomfort from the heel cord tightness. Sit up from supine. Independent, no aids other than having ankles held down by therapists which is within the range of normal must achieve the sitting balance. Pull up patient hold the leg clothing the pull up hem, pull up cushion the elbow, begin the pull up and then the pushes the at the least one elbow, turn to side and then push up patient will roll to side and then the push up with the both arms to achieve sitting balance. Two hands and knee and then sit up roll to prone, two hands and knees and the side sit or the other sitting balance. Rise up from prone position. Independent, no assistance required. Goer Science can bring himself to his feet from the most push on the knees, assume erect the posture. Chair to standing, patient pulls the himself to his feet with the eight chair the pushes on the chair to achieve upright position. Chair on the sitting, then the standing patient pulls the himself to sitting position in chair. Then the pushes the himself to upright position using the chair. Patient should not be placed on the edges of the fetal with the tightly folded supportive and the knees flexed in 90 degrees. Sitting balance. Stable, unstable. Stable is not unstable. That means the patient sits erect but cannot recover balance if it is lost or a patient is unable to maintain his balance without the support of his arm. Vital capacities, measured settings, talking highest to reading, to take with height into consideration, height, weight, hand grip, and the measure with the hand grip diameter talking the highest to the reading or for left right hand keep arms sit during the measuring. The physical therapy includes the stretching, muscular stretching, and gait training, thus increasing the efficiency functional activities of the including ideal and transfer. Strengthening deformity muscles by performing the patient fight the passive force by an active effort is own. Disability from weakness must be distinguished from the causes by contracture. The essential tenderness, the fat contracture in the face of the loss of the muscular support should be monitored by the physical therapist initially, such as the congenerating mechanical, the help maintaining proper body alignment. Eventually, they contribute the ability loss. Strengthening the tightness, the muscles, the prevention of the contracture. Overuse the strengthening a contracture should not be avoided because it produces pain and stimulates the stretch reflex. Maintaining dynamic flexibility by an active effort, the muscles is good way in contracture. Passive stretching the contracture, partially hip flexor, TFL and the heel cords can prolong functions and decrease the energy the cost of the muscular activity to the patient by the balancing agonist and antagonist. Stretch positioning prone to stretch hip flex, the daily active assisted exercise can significantly lengthen the period of functional ability. If a patient having a heel cord contracture with quadriceps and gluteus weakness, the straining the heel cord may be his ambulation and should be checked casually before the giving the stretching program. Now the PNF technique, neuromuscular facilitation, joint mobilization, positioning, moist heat, gait training in parallel bars, activities like the swimming should be performed. Thank you so much.